evening to all the wonderful people who have joined today. This is your host, Dr. Ifra Shakil, warmly welcoming you all to today's webinar. Well, I would like to extend a warm welcome to Dr. Nirav Gada for coming on board with us. Thank you for joining as a guest speaker for today's webinar, Doctor.
Yeah, most welcome.
Well, today's topic is Hybrid CorticoBasal Implantology Concept, an approach for treatment of full arch situation. So, this webinar will provide insights about the principles of both conventional implantology and basal implantology. And Dr. Nirav will be discussing about the immediate loading and ultimate patient satisfaction.
There was a time when we used to make complete dentures. We still make dentures, but as time is going ahead and implants are gaining more and more approval from patients, we are doing more and more implantology, and with a lot of success. But still the age old techniques which were there, which were being followed, where we place the implant and wait for 3 months, and after that then we load it. And instead of that, if you give the patient an option that I will give you fixed teeth within 6 days or 7 days, and that also they are not cement retained. This is a proper screw retained kind of a prosthesis, which we can change later whenever if you want and if need be. So that is all about hybrid corticobasal implantology that we are going to see. Why is the screen not moving ahead? So what are the types of implantology? So, as we all know, there is a regular two-piece implantology that we have been doing since ages. Then came Paulo Molo, and he brought in tilted implantology. And then there was a basal implantology concept that was introduced by Dr. Ide. And this is a total mixture, a hybrid corticobasal implantology, which is a
Doctor, sorry
mixture.
to interrupt, but your slides are not changing. It's stuck.
Why, why, why? Now
You need to switch on the PowerPoint presentation, Doctor.
I switched on the PowerPoint presentation.
No, it's stuck, Doctor.
It's stuck again.
Yeah.
It's not changing.
Yeah, it's not changing, Doctor.
Mm, Now
I guess every 2 minutes it's getting stuck. No, still not changing. It's the same.
changing now.
No, Doctor.
Why is it not changing? I also don't have any idea about. Now
Just a moment.
आजकल कोई ब्लैक एंड व्हाइट टीवी लेता है मनी
No,
ऑर्डर
Doctor. It's still stuck. Yeah, now you can probably put the presentation on.
yeah.
है क्या राइट साइबर कैफे जाता है क्या और ये सब तो पुरानी आते हैं
Or probably you may be having network issues, Doctor. So that's why your screen is getting stuck.
Okay. So now
No, it's still stuck.
1 minute. Let me check.
Maybe you can rejoin, doctor.
Rejoin.
Yes, maybe like end the session and then join again.
Okay.
To all the participants, thank you for patiently waiting. I know there are some technical issues, I guess, because of network issues. So hopefully, Dr. Nirav will be able to join us soon. So meanwhile, you can just drop in your questions in the Q&A box. So we'll be addressing that at the end of the session.
Now.
You can share your screen, doctor.
Now.
Yeah, now it's fine, doctor.
Now is it changing?
Yeah, now it's changing. But your video is not visible.
Okay. I'll do something about it.
I guess you can make it blur or keep a normal background.
Yeah, that's okay.
Yeah, now it's fine, doctor. You may continue.
So, where was I? Yeah. So, there are two types of many types of implantology that they are practicing, and the regular two-piece implantology is what we have been practicing since a long time, and after that came Paulo Molo. He brought in tilted implantology, or you can say all on four. And then Dr. Ide introduced us to basal implantology, where we engage the primary bone, which never resorbs. And then we introduced hybrid corticobasal implantology, which is both a mixture of tilted implantology and basal implantology. So when we are doing regular two-piece implantology, looks something like this. You put straight implants, wait for 3 months, and then load it like a picture perfect thing. This is gold standard, and a lot of people still do this. But we can definitely move ahead of this. We come to all on fours and all on sixes. This is all tilted implants, but again the only difference between this and this is basal implants. Now in this basal implants, what you can see is some screws, multiple screws which are engaging different parts of the maxilla and the mandible, so that we can load it immediately. Okay. Even zygomatic implants are actually called basal implants. They are not regular implants or two-piece implants, but they are being shown as two-piece implants, but actually they are basal implants. So, what is hybrid corticobasal implantology? It is a mixture of both basal implants, and it uses the principles of basal implant and the technology of uh, our regular two-piece implants. So here we use a different design which is very active, and along with that we use multi-unit abutments, and we load the teeth immediately using the principles of basal implantology. So what is corticobasal implantology? Any dental implant that is placed in such a way that it engages and takes anchorage from an area of bone which will not undergo any resorption is called a basal implant. So what are the types of basal implants? So this is one, a compressive implant. In compressive implants, there are single piece and multi units. Okay, and these are the BCS implants, and this is the second type. And third is the latest design, which is that you can see, this is the implant from Quickdent, which is a cortical TPR, and it is a very aggressive design. You can see the threads and the polished collar on both the ends. So the concept, I will explain the concepts of basal implantology ahead, and how this design benefits it. We will come ahead and we'll explain it. Okay. So what are the basic principles of hybrid basal implantology? So there are particular areas of engagement. So, in the maxilla, we are trying to engage the areas like the pterygoid bones, the zygomatic bones, the septa, and the sinus floors, and also the canine pillars and the nasal floors. Also, the orbital rims, if required, can be utilized. So, these are the areas. Generally, these areas are sites of, you can say, muscle origin and not insertion. So these are the sites where the muscles originate from, and the muscles of facial expression and the muscles of elevation for the jaw and depression. So what happens, these areas, they never undergo any kind of resorption. So we have to utilize these areas to take engagement from, and if you engage these areas thoroughly well, and if you give a good occlusion, generally these areas are the most stable areas from where no bone resorption will ever happen, and the implants will remain stable, and you can load these areas immediately. Also, you have an option in cortical TPR that, because it is a rough surface in the middle, you can also wait in case you are in two minds that you cannot engage, you have not engaged these areas properly, or you have a difficulty, and but you have engaged the other parts well. So you can wait and load it later also. So in the maxilla, the region A is the pterygoid bone. You can see there are two plates, the medial pterygoid plate and the lateral pterygoid plate, and the area between them, it gets fused to the maxilla. And our target area is that area, or the zone of fusion. And once we engage that area well, generally it does not undergo any kind of a resorption, and it helps us to uh, avoid direct sinus lifts in case where there is very high pneumatization of the maxillary sinus. And the area B that you can see is the zygomatic bone. The zygomatic bone is that area which under is not a part of the maxillary bone, but it is a extension of the zygomatic process. Now what happens is that it is in the origin point is in contact with the maxillary bone, and because of its close proximity and because of its dense cortical nature, you can generally utilize this bone to take anchorage from and load your prosthesis in case when the maxilla and the alveolar bone is too small and when there is very high pneumatization. And Then there is the infraorbital rim area, or the area of the infraorbital rim, which is again very high cortical area, but generally we don't engage those areas unless and until required. And as you come ahead in the center is the premaxillary zone, where there is the nasal floor. The nasal floor is very high and dense corticated bone, and that is our primary area from where we take anchorage. So these are the sites for maxilla, and now we'll go to the mandible. Now in the mandible, the most important areas are in the mental to mental foramen area, which is the interforaminal region. Now in this area, generally we engage in the region of canine and the first premolar, because the structure or the shape of the mandible is such a way that it is a U-shaped bone or a V-shaped bone, we can say. So in that area, the 3-4 region on right and left side, they act as an important pillar. And again, in the posterior region, we engage either the lingual cortical plate and below the level of the mylohyoid ridge, and in the buccal areas, you engage the buccal cortical plate. Okay, so these are the areas for uh, engagement in the mandible for the bicortical implants. Okay, so these are the main sites that we will always utilize. Now there is some difference between bicortical implants and uh, normal two-piece implants. So the bicortical implants, they get osseo-fixated, and the two-piece implants, they get osseo-integrated. So generally this is a gradual biological process of bone growth towards endosseous implants by mineralization in the matrix. But what are the advantages of osteofixation? They are very high primary stability, which allows us to load the areas. And in osseo-integrated implants, there is very low primary stability. And in osseo-fixated areas, there is no importance to alveolar bone. But in osseo-integrated areas where you want to do two-piece implants, you need a minimum width, and we always respect the alveolar bone. But what if we can take the benefits of both osseo-fixation and integration into one implant and give it a better way to, or present a better way to uh, load it immediately, because it has both the aspects. It has a very high primary stability, also it is a rough surface, so it will integrate fast instead of an osseo-fixated implant which will integrate over a period of 2 to 3 years. So if we introduce both the aspects together, it becomes gold. So that is what we use, is the hybrid implants. Now these are the methods of engaging the mandible in the interforaminal area. As you can see in this first picture, it is in the 3 and 4 region. And as you go behind, we engage in the lingual cortical plate below the mylohyoid ridge, as you can see. Okay, and in sometimes when the mylohyoid ridge is not very uh, sharply present, and if there is a lot of resorption, we engage the base of the mandible or the buccal cortical plate. Okay, so these are the sites or placement methods in the mandible. For the maxilla, as I have already explained to you, for the maxilla, what we engage is the pterygoid bone. The pterygoid bone is the most important and the most critical thing to avoid uh, failures in cases. And then after the pterygoid bone comes the septal area, which is present in the in maxillary sinus. Sometimes these areas are present and we can engage these areas also. And again, another area which is commonly used is the nasal floor, as you can see in the picture on the right side. So this area is very commonly engaged. And again, we also engage the canine pillar as you show in the center. This area is one of the most critical areas and one of the most difficult areas to engage. But many times we can or we should engage such areas if required. So these are dense cortical areas which will not undergo any kind of resorption and will provide us with excellent primary stability. So we can load our implants immediately. Oh, also, basal implantology introduces the concept of lingualized occlusion. In lingualized occlusion, our occlusion is basically avoiding anterior contacts, and it is creating a bilateral equal contacts, and it develops a lateral pattern of chewing. But what we do in hybrid corticobasal implantology is generally we follow the regular implant occlusion that we give for full arches. In regular full arch occlusions, what we give is an anterior and we can give an anterior guidance, and also along with that uh, we can give a canine and a joint guidance with the premolars. So this is just one case of basal implantology to explain you what basal implantology is exactly. Here is a case where it's a completely edentulous ridge, and here we have used a flapless technique with one or two burrs. Generally, we place the implants. In the maxilla, you can see we have engaged the pterygoids on both the sides, a double pterygoid, and we are engaging the nasal floor from premolar to premolar region. In the mandible, again, we are engaging the lingual cortical plates on the posterior side and a little bit of the lower anteriors in the interforaminal area between 3 and 4 region. So these are the sites where we generally place our implants. And you can see now in the X-ray that we have used the BCS implants and the compressive implants in the lower. And here we give a metal trial and we load the prosthesis within 3 days. Okay, this is the kind of occlusion that we give. Here you can see the occlusion is only on 4, 5 and 6, mesial part of 6. That's it. These are the three areas that touch. But this is a lingualized kind of an occlusion used in basal implants. Now, what are hybrid corticobasal implants? So this is the design which I was talking about. Unlike regular basal implants, these implants engage the first cortical, which is the alveolar bone. So we respect the alveolar bone also. The middle cortical, which is the buccal and the palatal cortices, along with the medullary bone. And the third cortical, which is the nasal floor or lingual cortical or the pterygoid bones. Okay. So the third corticals are the nasal floors or the lingual cortical plates or the pterygoid bones, leading to high bone implant contact area. Now this high BIC allows us to achieve rapid osseointegration along with high primary stability, and so we can load our implants immediately. This is the design of the corticale TPR spiral implant, which we are using. Here you can see this, the upper part is the polished collar, which now major companies are trying to use, so that this polished collar prevents further disintegration of the bone and microorganisms reaching to the crestal part. And also the lower end also you can see is a polished collar, because when we engage the nasal floor, so it goes beyond the bone, so we try to keep that area polished so that there is no kind of a bacterial integration coming from the opposite side also. These are the drills that we use. The this you can see is the lance drill, which is one of the most important ones. We have the long and the short lance drills, and we have a 2.0 30 mm drill, and we have step drills ahead to widen the bone as and when required. And there is a hand ratchet with which we place the implants with our hand. Here we don't use micro or motor driven implantology. Generally we are doing it with our hand ratchets. And then to do some fine adjustments, we also have a normal ratchet. What are the steps that we follow in achieving immediate loading? So first is the method of placement. So now these are although hybrid corticobasal implants, but the principles remain the same as that of basal implants, where we are in the maxilla, we are engaging the pterygoids, we are engaging the zygomas, we are engaging the nasal floor, and in the lower bone we are engaging the interforaminal area again between the two foramens, and we are engaging the two cortices, that is the buccal and the lingual cortice here. Or we can also do lingual cortical engagements or buccal cortical engagements as per the bone situation. After we do the After we place the implants, what we do is we connect the multi-unit abutments. Now these multi-unit abutments are connected as per the angle of the implant that has been given, and once these multi-unit abutments are connected, we close the flaps, we stitch it up, and after that what we do is we take an open tray impression. We also have scan bodies, but for full arch, I generally prefer the old school technique, because these scan bodies and still I have faced a lot of errors and while doing the procedure, uh, because in the when the final prosthesis comes, so generally we had to repeat the prosthesis. So still this for full arch technique in any implant system, generally there is not a proper methodologies that has still been developed. So I prefer the old school technique of a open tray impression post, and we take an open tray impression. So this is how we take an impression, and once the impression is taken, the technician will pour the impression and he will give me a jig. Now he will prepare this jig and give it to me at the same time. And then what I will do is I will do one screw test. Now, here what is important is that when you put this jig in the mouth and when you do a one screw test, in that the area from the other side should not get raised, and the entire jig should be stable. And once you do it with the most terminal abutment from the right side, repeat the same procedure from the left side and check whether there is any error. Once you confirm that there is no error from both the sides, we connect all the implants again and check whether all the screws are engaging the multi-units properly. After this procedure is over, that means the jig trial is confirmed. That means the impression is completely okay. What the technician will give me is a jaw relation. Here in the jaw relation part, what we do is first we, as we do for complete dentures, is here we can just make a double tray system where we use a TI bases and engage the multi units with a single tray, and on that we make some serrations and engage another tray and just continue to take a jaw relation as we take for a regular complete denture. And once we have done that, what we get is a, a bite. Now, on the based on that bite, the technician, he will mount it in the on the articulator and he will scan it, and then later on what he will give me is a digital wax up, or you can say a digital setting trial. Now this is what is a digital wax up. Now this digital wax up I put in the patient's mouth. Here we check for all the aspects. We check for occlusion on the right side, on the left side. We check for all the guidances, that is the anterior guidance, and we also check for the lateral guidance or the group function. And once we do that, and if we feel that everything is okay, then we can ask the technician to go ahead and proceed like this. And if you feel there is an error, you can immediately do the corrections in the same wax trial and send it, like you can increase the bite or you can reduce the high points, so that the same things will be replicated in your final prosthesis. After this that is done, there is a metal trial that is done, but because our jig trial is confirmed, generally metal trials are totally okay. And once the metal trials go okay, and after that will be the bisque trial. In the bisque trial you will check for any high points or any problems that have come, and then you will go ahead and do the final fixing of the prosthesis and finish the case. Now, like for normal two-piece implants, what occlusion we give? We give a similar occlusion with hybrid corticobasal implants. As you see in the center, the lower picture, when the two central incisors are touching, there is a gap behind. This is called as anterior guidance. And on the right side, when the patient moves on the right side, there should be group function where the canine and the premolars will touch, and there will be an empty space throughout. So now this was how we go ahead and do the cases. Now I would like to show you a few cases which we have done and how we have gone ahead. This is a case where you can see this is a very simple case actually, where the patient is completely edentulous, and as we see, the we have very good amount of bone in the anterior zone, in the lowers and the upper area. And still what we have done over here in the maxilla again is engagement of the nasal corticals and also respected the alveolar bone, and we have engaged the pterygoids, and in the lowers again in the interforaminal area. And once we connect the multi units, after that this is the final prosthesis in picture. Okay, so now the prosthesis that we have made for her here is a hybrid prosthesis. In the hybrid prosthesis, generally there is a bar, and on that we use either acrylic teeth, or nowadays we have something more superior than that, that is HIPC, which is a material from Brident, which is a very good material, and it gives us excellent strength and aesthetics both. And it is very light, so it is very comfortable and better for the integration of the implants and the future health of the implants. Again, this is another case where you can see the entire occlusion has gone, uh, and the teeth are highly mobile, and the patient wanted to save the upper left teeth, but we explained to the patient that we won't get a proper plane of occlusion and our entire prosthesis will fail. So the patient agreed for extraction of all the teeth, and we went ahead and we did a full mouth rehab, but we did not touch the impacted third molar. So instead of that, we generally place the last implant on the left side in such a way that the tip is coming close to the first molar region. So this is how, again, we do the wax trials for the patient, and once the wax trials are confirmatory, we go ahead and give a beautiful smile to our patient. These are all done within 5 to 7 days. This is another case where you can see the entire occlusion is gone for doldrums, and all the teeth are either mobile or worn out. Patient was advised complete extraction, and here we did an interforaminal placement in the mandible, and here you can see on the right side I have engaged the lingual cortical plate, and in the uppers again it is the same, the nasal floors and the pterygoids. Again, we do the wax trials. This is a wax trial which is done with the acrylic teeth. And once everything was confirmed, we changed to a graphene prosthesis. And this is the final prosthesis in the patient's mouth. And the patient is extremely happy. This is a different case that we did, which is a case of, you can say, a class 3 kind of an occlusion that the patient had, where the lower jaw was ahead and the upper jaw was behind. But in the upper jaw, all the teeth below the crowns were all gone, as you can see, and the patient wanted a better smile. So we decided to go for an upper full arch, and again the implants are placed in such a way that we achieve the nasal floors, the all on four, and the pterygoids. And you can see the design of the implant. It is so aggressive. It holds so well to the pterygoids. Again, we do impression, again an open tray impression, and then we give her a trial. Now in the trial what we did is, from a class 3 kind of an occlusion, we tried to give her an edge to edge kind of an occlusion, and we gave her some lip support, and the patient was amazed with the beautiful smile and a very good lip support that she got, and she was really very happy with the final prosthesis. So we converted a class 3 kind of an occlusion into a class 1 kind of an occlusion. Again, this was another case where you can see that there is no bone in the maxilla, complete atrophy. Here we had decided to do quad zygoma. So we placed four zygomas, um, and this you can see are the zygoma on the right, and this is on the right and on the left. And this is the kind of occlusion that we get. So this was a quad zygoma case that we did. This is another holistic approach where we had a little bit of difficulty. As you can see, the patient is very old, a rare case, a different kind of a case that I've done. And here you can see the patient is above 85, and she has implant supported denture, but she's not very happy with it. And there is no bone in the posterior area in the lower jaw, as we show you in the x-ray. And in the upper zone there is hardly any, well, the teeth below, it's a floating bridge, joint bridge. So again we have impacted third molars on both the sides. So we decided not to touch the impacted third molars, and we decided to do implants in the maxillary area, pre-maxillary area, like in all on four. And in the lower, what we did is we placed uh, two basal implants, lingual cortical engagement, and bent them. And this we can say is a holistic approach where we are using basal and two-piece implants, and we have loaded this prosthesis immediately within 7 days. Again, we get a very good occlusion. Patient is extremely happy with the aesthetics. This was a very nice case, and is a very simple case with a lot of bone. Here, again, the patient was not ready to wait. When we gave him an option that we can load it within 7 days, he was more than happy. We got a very good placement of the implants in the premaxilla and in the pterygoids. And this is how we close the case with a hybrid kind of a prosthesis. This was a very difficult one. Here what we have is a complete atrophy of the maxilla and good bone in the mandible. But here what we planned are zygomatic implants and pterygoid implants, and two implants in the anterior nasal bone. This two implants in the anterior area, there is no bone in the alveolar area. So these are nasalis implants engaging right from the palatal side. And this is the lower jaw. Here we have again placed normal interforaminal implants and posterior implants and loaded, put multi-unit abutments. And again we go for a wax trial, and it is repeated in a similar manner. So here we did a ceramic prosthesis because we had very good integration and very good torque. So this was a very young boy. So this was a 30 years old boy, 35 years old, and extremely poor maxilla. You can see no bone situation. Here we had one single root piece in the upper area. We removed it and we put a nasal implant, and we placed zygomatic implants and pterygoid implants for the patient. And then we loaded the prosthesis immediately. Also in the lower, later we added implants and we gave him a prosthesis, but that was a delayed kind of a prosthesis. So this was his final smile. This was another lady. Lower jaw there is nothing, and in the upper jaw you can see all carious and badly destroyed teeth. So when we explained the patient, so the patient was extremely happy and she went ahead with a full arch. So again over here we can see an impacted third molar, so I didn't touch it, and we placed a pterygoid on the other side and implants in the premaxillary zone, and in the lower we had very good bone, so again we placed implants and we gave her a ceramic prosthesis. So this is her final smile. You can see the entire smile has changed. The patient is really very happy. Also, with this kind of areas, many times we get segments or areas with high pneumatization. And here what we do is, in such areas you can see where there is no bone, and instead of doing a direct sinus lift, I place a pterygoid implant. And many times if I get a very good torque also, I wait for 2 months and then I can load it immediately after 2 months and achieve excellent results. So instead of this is another segment case where the left side is completely nice, the patient is not ready for any kind of loading for that. So there we do such kind of prosthesis. Again, here we can see in the lower area everywhere there is deep lesions, and you can already see two implants have been done for the right left side. So we removed all the teeth, cleaned the granulation, placed immediate implants and loaded it immediately. These are all segments that we have done. Again, you can see very high pneumatization and a direct sinus lift which has failed, and there is a fracture of the implant. We placed another two implants and then another pterygoid, and we have done a segment over here. So take the road which is very less traveled, I would say, and is a totally different approach that we do. And this is my number that we are using, and we also do a lot of shadow courses where we give others an opportunity to learn from us. In case if anyone is interested, uh, do let me know, and if there are any questions you can please ask me. I would definitely like to answer.
Yeah.
So,
Hi, doctor. We have a few questions here. So the first question is 30 drill specifically used for which cases?
generally, 30 mm is the length, and the width is 2.0. So the 30 drills are generally required for the pterygoid bones. So now what happens is that there is how far the pterygoid bone is from the maxilla is dependent on the amount of resorption of the maxillary bone. If the maxillary bone is resorbed less, what happens is then we have a very high tuberosity, and to engage the pterygoid, we need very long drills. So this is the problem with so generally in that case we use 30 drills so that we can engage those areas properly and achieve our high stability zone. Any other question?
Yes, doctor. We have another question. What cement is used for cementation?
If we are using any cement, then generally it's a dual cure cement from 3M. But generally we do screw retain kind of prosthesis. So in screw retained kind of prosthesis in hybrid system, we don't require any cement. It is totally engaged with small screws or the multi-unit apartments. So it's a completely retrievable kind of a prosthesis. But if you are doing basal implants, cement retained, then you may require cement.
All right. So the next question is, can we use a combination of basal and hybrid corticobasal implants?
Yeah, I have used it as I showed in one case. It's a holistic approach, but it's very rarely used. But does, if required, you can use, but there are no proper documentation for that as of now.
So the next question is, how to convince the patient for full mouth rehabilitation?
Generally, when you explain the when you take an OPG, generally as a corticobasal implantologist, I am not a very big fan of CBCTs. Generally, what we want is an OPG, and we generally sit with the patient with pictures of other patients, and we explain what is the plane of occlusion that they have, and what we want to achieve, and what are the kinds of prostheses that we can give, and how we can give them a third occlusion or a third set of teeth, which is very good, and that helps them to decide and to get motivated to do a full mouth implant.
All right. So the next question is the cost range for full mouth implants that we can tell the patients for corticobasal implants.
Sorry.
The cost range of full mouth implants, doctor. What is the cost we can quote to the patients?
Generally, we charge from 4.5 to 6 lakhs, whatever, for full mouth cases. And depending on what is required, like zygomatic implants, or if they are not required, then how and what. So that is how we go ahead.
Okay. So the next question is, which lab do you prefer, sir, for your prosthetic work in Mumbai?
In Mumbai, we are associated with Osteocentric Lab uh, with Hemant Khoth, and I am doing most of my cases only with him because he has a very sound knowledge of the system, and also he is giving very good aesthetics for my patients.
All right. So the next question is for pterygoid implants, which company is the best?
I have tried many companies, like I have tried Norris, I have tried Bioline, I have tried a lot of companies, but in the end, I would say you should definitely try Quickdent because Quickdent is one of the most aggressive designs, and you will get excellent torque and confidence to load implants.
So the next question is duration of HIPC. How long does it survive?
So it's a very nice material from Brident, and it's a composite, and it's very lightweight, and general survival rates is from 5 to 7 years. That is what they say, and it gives excellent aesthetics and chewing areas, chewing capabilities also. So it is a very good material which we use.
Okay. So the next question is, can we give cantilever on zygomatic cases?
Uh, the whole concept of corticobasal implantology is to avoid cantilevers. Otherwise, why don't you finish the case on an all on four? If you want to finish the case on all on four, or a zygomatic implant, and if you see, generally the zygomatic implant will come in the area of 4 or 5 again, and 6 will be a cantilever. So if you want to give a cantilever, then you can give, but then that molar will not touch or will not be in occlusion. So we don't prefer that. I generally add a pterygoid because it's not a very big deal for us. We immediately add a pterygoid, and you should learn and you should add a pterygoid implant so that we can give excellent results and
All
you
right.
cantilever.
Okay, so we have another question. What is the drilling protocol for hybrid implants?
So the drilling protocol for hybrid implants is generally we have a lance drill like we have for other for normal basal implants. So first thing we use is a lance drill, and after the lance drill is used, then we decide how the bone quality is. So if I feel generally in the maxillas, if I feel that the bone quality is not too good, if it is very soft, then we add another 2.030 drill, and just engage the nasal floor, and then directly place the implant so that it compresses the bone, the palatal and the buccal bone while placing the implant, and it gives us a very high torque. But in many cases, generally, if the bone quality is good, you have step drills also. So then we can widen uh, the the surgical drill, the surgical hole, and the whole goal of doing anything and everything is that when you are placing the implant at that time, you should be achieving a torque between 50 to 80 newtons. If you are crossing 80 also, then also it's not very good, 80 to 90. And if you are less than 50, then also it is not very good. So the first drill will decide on the type of bone that is there, and then we take the call for the second and the third drill, and then we decide place the implant.
All right. We have a few more questions, but actually, we've crossed the time limit. So we'll be ending the session right now. So
Okay.
thank you, Dr. Nirav, and once again, thank you to all the participants for patiently viewing this webinar. And once again, thank you, Dr. Nirav, for being our guest speaker today.
Yeah, I'm most happy to share my knowledge. And if there is anything, you can contact me on Facebook or on Instagram, uh, or my number is there. You can just contact me, and then we can go ahead if there is any problem. We also are doing shadow courses where I am giving one-on-one kind of hands-on to the participants, and you will also get a chance to see our cases along with us. And because you, observing and assisting is the best way to learn, and then you also have to replicate those things in your own practice, and it is always going to be that you will fall because nobody learns without falling. So it's always an opportunity to start learning and take the step ahead. Thanks.
All right, Doctor. Thank you so much. It was a wonderful presentation, and thank you for patiently answering all the questions.
Definitely. If
All
there's
right.
anything else also, they can contact me and I can personally answer it.
Sure, Doctor. Thank you so much.
Yeah.